Hi everyone, thanks so much for tuning into the channel. I'm here with Austin Miller. Tell us a little bit about yourself, Austin.
I grew up in Northwest Arkansas. I've been in a really like a pretty small town, I guess you call it like a suburb of Fayetteville, even though Fayetteville isn't like a especially large town in comparison to the rest of the country. But I grew up here, and I decided I wanted to get a little bit further away for college. I got my undergrad in psychology in a more rural town in Arkansas. It was during that time my best friend that I met in college actually had a C6 incomplete spinal cord injury. Just living, I mean, doing something that like I wouldn't have done, but it was, just living his normal life.
Yeah.
He went away to rehab for a few months at Craig Hospital in Colorado.
Wow.
And when he came back to school, he needed a couple of people that he trusted to be caregivers for him. And
Yeah.
um, so he came back to school, and me and our buddy.
Okay.
So when Tyler, my buddy, came back from Colorado, our friend Trent and I became his caregivers, so that way he could make that transition
Mm.
back to his normal life with his new level of function.
Yeah.
And it was during that whole process of watching him reintegrate into our normal life, and we were having to learn, like, what does this look like now? Because
Mm-hmm.
Tyler was in the military and he ran. We would play ultimate frisbee, we'd play disc golf. Tyler was interested in all sorts of stuff like fishing,
Mm-hmm.
hunting. And so as just friends, but also like serving a completely new role now, it was like
Yeah.
watching him struggle with having to come to accept his injury and
Mm-hmm.
his new level of function. And so that was a really big, um, obviously a big experience for him. So I don't want it to seem like I'm making it about me, but it became a really big, uh, formative time in my life, realizing that I had this sort of passion in working with people who were at this pivotal point in their life. Because before my plan was to go off to grad school and become a clinical psychologist, and then
Wow.
when I was walking alongside my buddy through this injury, I was like, I think I want to work. Like, I want to work with people who are going through something like him.
Yeah.
And that turned into me. I graduated with my degree in psychology because I was on scholarship. I didn't want to take out loans for undergrad. And so
Mm-hmm.
I just did that. I worked for a year to save up money so I could go back and get the prereqs I needed to apply to PT school.
Mm-hmm.
And I knew from the get go that I wanted to do neuro when I got into school. And so the school that I went to is a systems based program. And so, like, the whole first year, you learn your foundational stuff, but you get your whole orthopedic curriculum too. And so
Oh
that
wow.
was a that was an arduous year for me because I was just like, let's just get to the neuro content already.
Right. Yeah.
But yeah, so I still live in Northwest Arkansas. I live in the town that I grew up in.
Yeah.
I love this part of the state. I love this part of the country. And I've pretty well decided that if I'm going to have an impact in this world, this is where I want to leave my stamp.
Yeah.
And so I expect I'll be here until they bury me. So
Oh, yeah.
yeah,
Thank you so much for sharing your story. There's so much to unpack there, but the biggest thing is your why is so powerful, and I think that's a huge part of the conversation we're going to have today
sure.
about just where the profession is, your why, and just your experience with navigating outpatient neuro. I'll let you tell your story too. Where you're in an outpatient neuro clinic?
Yeah, so I graduated from PT school in May of 22, and in Arkansas, they don't have temporary licensure privileges, and so
Mhm.
I spent, May through July studying. I took my boards at the end of July, waited the week, got my licensure. I had actually accepted a job back in May, like the week I was going to graduate. I had gotten a
Oh,
call
wow.
from a facility where I had interviewed, and they offered me a job as an outpatient neurotherapist, and so
Wow.
I'm 4 years out of school. I'm currently in my second job, but both of the jobs that I've done have been in the outpatient neuro setting. And so, yeah.
Nice. Nice. Do you primarily work with spinal cord injury patients? Is it a mix of neuro patients you see?
Yeah, that's a great question. So, while we live in a more robust area of the state, second only to like the Little Rock area, which is our
Mhm.
capital, our state capital.
Mhm.
Um, there's not a lot of neuro rehab access in this area, and so we're one of two, arguably three clinics that provide outpatient neuro rehab, and so we get quite a variety. We get the stuff that we learn about, like the big stuff you learn in your neuro curriculum. So your
Mhm.
MS, your stroke, your spinal cord injuries, your traumatic brain injuries.
Mhm.
But we also tend to get the more like zebra diagnoses. So I've treated people with dermatomyositis. I've treated people with inclusion body myositis,
Mhm.
post polio, and in the last couple of years, I've particularly taken a big interest in vestibular and concussion rehab. And so I am actually working toward more specialty certifications so that we have a reason to grow our vestibular caseload in Northwest Arkansas, because I think that's a population that is wildly underserved.
Mhm.
Not necessarily because, I mean, I think part of it is poor access, but also
Mhm.
think it's just like poor awareness
Yeah.
on the part of the layperson. So like
Yeah.
a person experiences dizziness or balance disorder, and like they just don't think about it. They just think like, well, that's a normal part of getting older, and they don't make,
Mhm.
they don't bring it up to their PCPs.
Yeah.
And then a lot of times PCPs are kind of like, well, dizziness, that sounds like it could be cardiology or ENT. And I
Yeah.
was recently speaking with an ENT, and the ENT was telling me that vestibular dysfunction is like the bane of ENT's existence. Like
Oh.
very
Yeah.
few of them really want to delve into that as a specialty. And
Yeah.
when they have to deal with it, it's just like they just want like a place to know they can send their patients. And
Yeah.
so I think it's a tremendously underserved population, and I'm just trying to increase awareness of the need, number one, but also the
Mhm.
access that these patients, but also the referral sources can supply
Yeah.
to. So that was a
Yeah.
long-winded answer. I do treat some of everything, but I would say in
Okay.
the last year, my caseload has gotten more and more uh, geriatric in regards to the vestibular imbalance disorders, and then I'm also trying to further develop the concussion rehab side of things too.
Awesome. It sounds like you have like a whole breadth of populations you work with, which is really cool.
Yeah, yeah, for sure. And I think that it makes it fun for the new grad that's just like, I just love
Mhm.
neuro, and I just want to be able to treat neuro. And
Yeah.
so in an area like this, you get like Arkansas has a wildly out of control stroke occurrences that happen every
Yeah.
single year. It's like the number 2 or number 3 cause of death in our state.
Wow.
And so there's a lot of people who have strokes, much less that have like, the traumatic stuff like SCI
Mhm.
or TBI.
Yeah.
But when you get to see a good variety of that stuff, it's enjoyable as a new grad because you get a lot of experience
Mhm.
getting to treat a plethora of stuff. And you may be able to speak more to this from your own perspective, but I really think that the thing that builds longevity is in a career is being able to specialize, because I feel like the tendency is you find something that you're like, I love treating that.
Mhm.
And if you can build a kind of program or support behind you that's like, that's what I want to do.
Yeah.
So that way you can, as you transition further into your career,
Yeah.
to just be able to see the stuff that just like really gets you out of bed in the morning. That's not
Yeah.
to say that I don't enjoy treating like spinal cord and stroke. I really do. But
Yeah.
I mean, my biggest area of passion and interest is the vestibular side of things. And that's really what is like driving a lot of the push for growth from my end in my
Yeah.
clinic.
Yeah, and I love that. And I'd like to speak on my perspective too, because I see some vestibular patients in acute care, and
Mhm.
I've worked in a little bit more rural areas, and just like you said, the level of knowledge that you have going into it, a lot of these patients come in first to the ER, they call a code stroke in them, they kind of go through the whole 9 yards with the
Right.
imaging and everything checks out. And
Hmm.
then you get there and you do the evaluation. And I've seen a patient with nystagmus at rest, like crazy nystagmus at rest
Yeah.
with no goggles. And it's just so fulfilling to help them be able to go from that. And then you do an epi maneuver in the bed, you check, like screen out all the red flags, and then they go home. So it's a very rewarding specialty and a very
Yeah.
rewarding field. So
And they think you're a miracle worker. Like
yeah.
I was just talking to some geriatricians this morning, and I was, there was one that was saying that she had experienced vertigo, and she came and saw one of my colleagues who is in a faculty position now, but like he was able to help her BPPV clear up. And
Mhm.
I told him, I was like, yeah, that's one of those things that is wildly intense and
Mhm.
uncomfortable for the patient
Yeah.
experience, but incredibly easy from a mechanical standpoint
Right.
to treat. And so it's a shame that people go weeks and months
Yeah.
with this positional vertigo and like
Yeah.
think there's no hope, you know?
Yeah. I like that you had mentioned earlier too that you worked with some more uncommon diagnoses in the field. Do you have any advice for students who are interested in specifically neuro rehabilitation who might have not had that experience?
Yeah, 100%. I think this is not the fun answer as a new grad, but I
Mhm.
think we have to get really, really comfortable going back to the literature. That's something that the program I was in really pushed, and I didn't appreciate as a student because you just have
Mhm.
so much on your plate. But as a
Mhm.
clinician now, it's like if I'm seeing a diagnosis that I haven't treated before,
Yeah.
then my only hope, if I want to give the best quality care that I can, my only hope
Mhm.
is to go back to the research and see what is being said is the best course of action from a rehab standpoint for these individuals. So I have treated some pretty rare stuff. Like I've had a couple patients with Friedreich's ataxia, which is
Mhm.
pretty rare. There's only like 15,000 people in the world that
Wow.
have it. So obviously it's kind of crazy that I've seen two people that have that, but otherwise, I'm only 4 years out of school. So
Mhm.
Friedrich's ataxia isn't one of those things that we focus on. Charcot-Marie Tooth isn't one of those things that we focus on.
Yeah.
So I would definitely say, like, go back to your textbooks, go to the literature, and just get comfortable interacting with that stuff. Because
Right.
if you want to come off as a competent clinician and you want to build up that patient rapport and that patient buy-in, um, you have to, number one, be willing to admit what you don't know, but
Mhm.
know that you are capable of learning. I mean, that's like the whole rigorous 3 years that we went through is like figuring out how to learn so we
Mhm.
can continue to be lifelong learners throughout the profession. So don't be scared off by these like zebra diagnoses by any means. Just do what you know how to do
Exactly.
and learn how to treat it, you know?
Yeah, I love that you had mentioned that, like from your perspective. I think in terms of like in the moment, sometimes you're an outpatient and like that information comes in that you might have not had before and was in intake paperwork. So also being able taking the perspective just to treat what you see, treat the impairments. I've worked with patients who've had like symptoms that present similar to like ataxia, like you said. I think they had like Clipper syndrome, which is
Mm-hmm.
super rare, but as long as you're treating what you see and educating them and honestly being honest with what you know and open to learning what you don't know, I think that's a great balance when you're, especially in the very beginning, being 1 year out of school.
Yeah.
I think the first year is the hardest because you're like developing your baseline for everything as a clinician. So just a lot, experience is the best teacher, truly.
Yeah, for sure. And I think you're right. I think that you probably, as a clinician, like as the expert in the room when your patients come in, you kind of have to figure out how to balance. Like, I don't want to tell them that I don't know what I'm doing, right? But you do want to be
Yeah.
honest with them. If it's like, look, you and I are in this together. Like, I'm willing to tell you that I'm pretty green in my career still, but what I
Yeah.
know that I can do is I can push myself to learn, and so that way,
Right.
like, I can give you the best care possible. And I think that
Yeah.
that's going to work especially well in rural areas,
Hmm.
because you may be the only therapist willing to take on that case, right? And so
Yeah.
um, I think that if it's something outside of your comfort zone and you know that there's another clinic nearby with someone, then like obviously feel free to like I feel like you might get better care from this person, but if you want to challenge yourself, like if you
Yeah.
know you have a colleague nearby that you would trust to be like, hey, I need some pointers because I have a patient that's presenting
Hmm.
like this, and I need to know how you would do things or how you advise me to do things. And
Hmm.
I think that that helps establish rapport with your colleagues as well. Because I feel like when we
Right.
get out of school, a lot of it becomes competition, right? Like we get
Yeah.
affiliated with certain businesses or hospital systems or whatever, and we're just like,
Hmm.
oh, this is the one you should come to. But
Yeah. Yeah.
really, if we care about like public health and what's best for our patients, then I
Mhm.
shouldn't limit my patients to what my weekly schedule dictates, right? Like if I don't
Right.
have capacity to take on more, then I need to hope that there's other clinicians that are willing and capable to take on that sort of
Yeah.
stuff.
Yeah. In terms of, since we've both worked in rural settings in healthcare, what advice would you have for students who are looking to improve their patient education? You did a great YouTube video or TikTok video on this a little bit
Yeah.
ago, but kind of educating your patient on physical therapy, what it is and how it can help them. Do you have any advice for that?
Yeah, I think that it's really important for you to be confident in the level of education that you have. I've only thrown out this piece a handful of times in the 4 years that I've been a PT,
Mhm.
but I do think it's important for people to understand that, like, I'm not just some dude that, like, got hired to show someone how to exercise. Like, I'm not just some, like, I had to go through doctoral level education to use exercise as medicine. And that's the phraseology or the verbiage that I really like to use is my whole thing, PT's whole thing is that we are utilizing the body's ability to move and to exercise to improve your functional independence and improve your overall health. And so my expertise is not in writing medications that might give you a quick fix to your problem, but how to use what your body can do right now to make you capable of doing something more. And so I think just letting them know, like, I'm here to be your teammate. I'm not here to tell you what to do so that you just like go do it and then you suddenly get better. Um, I'm your teammate, and the what I bring is the knowledge of how can we improve what you've got right now, which you are dissatisfied with. So that
Mhm.
way we get to a point where you are satisfied with your level of function. But then you have to tell your patients, but you play a pivotal role. Like this is not the same sort of situation where a doctor can just give you medication to like lower your blood pressure. This is
Yeah.
something that you have to be willing to take on, if not on a daily basis, on a multiple days per week basis, because we're
Mhm.
not going to see the improvement you want if we don't have the participation. And there's probably more kind ways or like maybe less rough around the edges ways to say that, but I mean, that also kind of comes from you to be like, build the confidence in the patient that like you are capable of this.
Right.
I have seen this level of success in patients like you before, and so if I know you can do it, you just have to believe that you will do it. um, but I think that giving them a bit of hands on the wheel in terms of like,
Mhm.
you have the power to make yourself better, and I'm just here to tell you how. That it really helps them feel empowered in being able to manage their health and manage their function. I think that largely, and I'm sure a lot of people agree with this, largely the healthcare community and particularly doctors. And I'm not necessarily saying this is their fault. I just think this is the heritage that we've come out of, is that um, we go to the doctor and we're told what to do and we do it, and maybe we get better, maybe we don't.
Mhm.
And I have spent a lot of my 4 years of my career telling my patients, like, no, you are in control
Yeah.
of your healthcare. You come to us with the problem and we tell you ways that we can try out to see if we can make it better. But you get to decide, like, no, I'm
Yeah.
not going to take that pill, or that exercise hurts, so I'm not going to do that one. I need you to give me something else.
Yeah.
Um, and so, I mean, I can't tell you how much of our job is really just like advocating for our patient to advocate for themselves.
Yeah. Yeah. Really.
I think I said it in that video too, but like, when I give you exercises, that's not set in stone. Like, I need your
Right.
feedback. How did you feel after doing that? That made things worse. You were nervous to
Mhm.
put weight on that leg with that exercise. Okay,
Yeah.
let's see if we can find out a way that we can do it in a way that you feel like is accomplishable, but is still therapeutic. You
Yeah.
know, and that gets tough to do. Like, you really have to get that problem solving going in your brain, but
Mhm.
but we've been taught how to do that, right?
Yeah. Yeah. I think that those are great points. And on top of that, have you run into patients that they're like they don't have really any goals once they come to therapy? They just kind of come because either they've had chronic pain for years. I know from the neuro standpoint, it might be a little different, but how do you go about those hard conversations with patients that it might take them longer to improve or their new normal might be different?
Yeah. And in more acute diagnoses like SCIs coming right out of inpatient rehab or strokes coming right out of inpatient rehab, I don't want to make false promises. right?
Mhm.
But
Yeah.
I tell them, like, look, everything the research suggests is that you can get better,
Mhm.
and my job is to push you to your limits so that we can optimize your function. And I do tell them, like, over time, you may develop worsening tone that may get better. It may not ever totally go away. There
Mhm.
are medical avenues that we can explore with your doctor. So I think about things like intrathecal baclofen, Botox, and stuff like that.
Mhm.
But I mean, just being honest with them that, like, I know what to do to improve what you got now. And I don't ever say, like, I don't know that you're going to get better, like totally better. I just say it's really hard to predict if or when a plateau will come, and
Mhm.
if that plateau will happen at your prior level of function. But what I
Mhm.
do know is we can be better than we are right now. Um, that becomes especially hard for patients if they don't have good support outside of the
Yeah.
clinic,
Yeah.
right? So if they don't have like adequate caregivers, if they don't have a supportive family, or if they don't have any family at all.
Yeah.
Um, but in that regard, that's kind of one half of your question. The other half of your question is when patients come in and don't really have goals, because that has happened. Like, I've done evals where a person was like, I came here because my doctor told me to, and I don't even know
Mhm.
what you can help me. And so
Mhm.
then I start the conversation with, like, well, like, what kinds of things did you tell your doctor you were struggling with? Like, they mentioned that you're having some balance issues, that you've had a couple falls. Can you
Yeah.
tell me the circumstances of
Yeah.
those falls? And then just talk through, like, well, like, is that normally a challenge for you? And I just try to identify something,
Mhm.
like, well, I haven't been able to, for years now, I haven't been able to get down on the floor to play with the grandkids, like play cars or Legos or whatever with the grandkids. And it's like, okay,
Mhm.
well,
Yeah.
I know you can make your muscles stronger so you can do that sort of stuff.
Yeah.
But if you identify something they wish they could do, if you
Mhm.
think it's realistic for them to do, and be like, we can work on that. We 100% can work on that.
Yeah.
Uh, and sometimes you don't get that. Sometimes they're like,
Yeah.
I don't think I'm struggling with anything. I'm like, okay, well, let's just do some
Okay.
testing.
Cool. Yeah.
I just do the test, like do a tug, do a functional gait assessment.
Mhm. Yeah.
Like, and if you've done everything and you've identified deficits and said, like, well, that one activity,
Right.
like, it was difficult for you to keep your balance whenever you were turning your head left and right.
Yeah.
Is that something that you normally deal with? And maybe they'll lie to you. If they don't want to be there, they're not
There.
gonna come, right?
Exactly. Yeah.
But I mean, I think that you just do what you're trained to do. Like, if they
Yeah.
don't tell you if there's anything wrong, go through your outcome measures, see what deficits you can identify,
Yeah.
tell them what deficits you've identified, and if
Mhm.
they're like, yeah, I agree with you, then see what you can barter with them to, like, see how often
Ex-
they'll come in. If you
Yeah.
say 2 times a week and they're like, no, they'll be like, okay, what
Yeah.
one time a week for a month?
Yeah. I think that goes back to your point too of letting the patient be in charge of their healthcare, but then also giving them options and finding what's important to them. Because patients oftentimes they care more about building rapport with them first and then treating the deficits after.
Yeah, 100%. And I'm forgetting who the author was. I want to say it's Lusardi, but I don't know if that's the gait as the fifth vital sign paper, or if
Mhm.
it's the motor recovery and motor learning paper. But there's a paper we had to read in our motor learning class that was talking about, like, what matters in motor learning, and one of the things was salience.
Mhm.
Repetition matters, um, intensity matters, salience matters. And so if I'm not making things salient for my patients, then they probably won't buy in. So that's why I think it's important for you to try to get them to identify
Mhm.
a situation or environment in their life where their mobility is limited.
Yeah. Yeah. Have you found any certifications helpful in your time as a clinician for 4 years that have helped you as a PT?
Yeah, for sure. I think that if you can get one of the big Parkinson certifications, which right now is
Mhm.
the LSVT Big or
Mhm.
the Power certification. I don't have my LSVT,
Mhm.
but I do have my Power certification. I think it helps give you a really good framework
Mhm.
of what kinds of strategies you can use with your patients
Mhm.
in order to promote their function. Of course, the big push in, like, most of neuro rehab, apart from your neurodegenerative disorders where you have to be worried about over fatigue, like MS or
Mhm.
myasthenia gravis or post polio. But in your big ones like Parkinson's, SCI, incomplete SCI, TBI, and stroke, intensity really matters. Pushing aerobic intensity really matters. And
Mhm.
so I think that the power program helps give you a framework outside of the research that just says like, well, we got to be pushing aerobics. We got to be pushing aerobics.
Mhm.
Um, it kind of gives you an idea of like, well, how can we do that apart from just like cycling or like walking fast on the treadmill?
Yeah.
Um, so I think that that's really good if you're trying to build a base of knowledge or foundational knowledge and like an approach to Parkinson's rehab in particular.
Mhm.
Um, the first certification I got out of school was about a year out, just about a year out. It was my certification in stroke rehabilitation specialty. It's through a company called Neuro Recovery Unlimited.
Okay.
If anyone, I don't know if other people are familiar with JJ Mattertinney, but she
Mhm.
teaches at a school in New York.
Okay.
Um, she is one of the people over Neuro Recovery Unlimited, and she puts on that CSRS course. And um, it's open to PTs and OTs, PTAs, and I think CODAs too. But
Yeah.
it helps give a lot of clarity to like what is good to promote in our uh, patients who have had strokes in terms of their optimal recovery.
Mhm.
Um, I think that some of it is like going back over things that we already learned in PT school, but it gives a lot more clinical input on
Mhm.
how to actually enact these treatments. Um, I don't know what it was like in your program, Alexa, but in ours, it's like even though like stroke is one of the things we spent more time focusing on, it
Mhm.
did feel like our time was really limited, and
Yeah.
so I told you earlier, like I knew going right into school that I wanted to do um, neuro, and so
Yeah.
my third and my fourth elective rotation were both in inpatient rehabs where I knew I was going to see
Nice.
a lot of stroke. So I think that might be unique to me, where I had a lot of exposure to it. But I think
Yeah.
a person who doesn't know that right off the bat and maybe is using their elective rotation to see like, well, maybe I would like peds or maybe I would like sports medicine or something, and then
Yeah.
they decide they want to go into neuro. I think that
Yeah.
CSRS course is fantastic.
Yeah.
um, if you're more interested in like vestibular stuff, there's a bunch you can go through. There's a company called Neuro 360.
Mhm.
I think it's Neuro 360, but it might be 360 Neuro. And then the American Institute on Balance
Yeah.
has several vestibular or concussion certifications, and so those ones I think are worthwhile for sure.
Nice. In terms of the clinical continuing education, is it
Mhm.
filling in context like more of case by case, how to interventions? In school, I feel like we learn a lot of the pathophysiology, which I guess in some way we need for the boards, but more in clinical context. Do those courses teach you how to like focus more on the interventions piece of it?
The CSRS course for sure does. Like it spends a good chunk of the time of the in-person time
Hmm.
talking through clinical cases. And I mean, you're surrounded by, I think the class that I was in for that CSRS course, there was probably 40 to 50 people. And there was like
Nice.
time set aside within that curriculum to um, discuss cases, but then there was
Yeah.
also like lab time in terms of like, well, they teach you some strategies and then you get to like practice on each other.
Mm.
The power course is like all set for like some of it is overview of pathophysiology, but then the majority of it is like showing how to not just implement the power moves, but how you could modify them based on what the
Nice.
patient's goals are.
That's really
So
nice.
the power moves are like a framework, and there's 5 different positions you can perform them in. So you can do them in supine, in prone, in sitting, in kneeling, or in
Mhm.
standing,
Nice.
right? And depending on what your patient's goals are, like maybe they're struggling with bed mobility, well, then
Mhm.
practice your supine power moves, right? And maybe you make
Mhm.
it more realistic where it's like, well, the big thing is like initiation of
Mhm.
movement. So you're going to turn the intervention into like, you're going to roll and punch, or I'm going to hold you back. You have to hold onto this resistance band and you have to like make big move, like think big, explosive.
Yeah.
Or maybe their issue is getting up off the floor. And so maybe you're going to do a transition of like the quadruped or kneeling power moves into the standing power moves. And so
Mhm.
um, that one is really, really thorough in just teaching ideas for intervention strategies. The vestibular ones, I actually don't. have a vestibular certification currently. I'm on a wait list for this year, which I'm not hopeful is going to happen because
Oh, gosh.
it's the University of Pittsburgh course, and I'm
Oh,
like,
okay. Yeah, I could see how that would get pretty
yeah,
crowded over
so
there.
I'm like number 14 on the wait list, but they emailed me and they were like, "You're accepted. You just if you don't get in this year, you get a guaranteed spot next year." So I may have to wait a
Okay.
whole other year, but but a lot of it, with vestibular, you're kind of learning a lot of the diagnostic tools as
Hmm.
well.
Yeah.
Um, and I think that's probably the bulk of what you learn,
Hmm.
because a lot of times you're going to be the only one testing those more like fine-tuned
Hmm.
vestibular identification tools.
Hmm.
But other than that, I've had friends, colleagues that have done like the AIB certification. And they do have at least a portion of the in-person course where it's talking about like strategies for um, interventions. Yeah, that was a super long-winded answer. I can ramble for a while.
I think my biggest gripe is like in terms of interventions, and I can
Hmm.
see like from the school's perspective, but just you learn in the field, but I think it's great that those courses kind of build on your knowledge with interventions and actually treating neuro patients in a lot of different conditions and settings.
Yeah, yeah, because even my longer neuro rotation was only 10 weeks, and
Mhm.
I mean I learned a lot of good stuff, but depending on your CI,
Right.
um, like you may not have a ton of support in terms of like processing through. This is what I had in mind. What do you think works about this? What do you think is like not good about this? And also being pushed of like, I had a teacher who is all about George Hornby's research on pushing high intensity variable gait training
Hmm.
and not focusing on like sit to stands or pre gait. And I'm totally on board with all that. Um, but I think as a student, a lot of the stuff you're processing is like, well, we just got to get weight bearing on that paretic limb, right? And so maybe
Hmm.
we'll do some pre gait taps or things like that. If you
Hmm.
don't have a CI that is up to date on what research says about it, number one, but number two, like doesn't care to push you that hard, then going into a neuro job as a new grad can feel especially challenging because it's just like, well, I don't just have this big plethora of like I don't have a big bank of interventions in my brain that I built
Hmm.
up over the course of clinicals. So no,
Yeah.
I totally agree. And I think, like you said, to PT programs credit, I think there is a lot of information they have to cover
Hmm.
for you to be able to pass your boards. And at the end of the day, everything is a business, and so it behooves them to make sure that their classes are passing boards because that's the metric by which we decide if
Right.
a program is good, right? Or
Yeah.
like better than another.
Yeah.
So,
I agree. And I think it really comes down to once you graduate and then you're building that foundation, you take stuff from your CIs that you're kind of building everything as you go. You're taking a little from here, from this person, and eventually becoming your own clinician. And I think that's
yeah.
one of the coolest things about when you graduate and become a PT is you can become your own person. At that point, you're no longer under the supervision of a CI, and how they would do it is how you sometimes feel like you need to do it kind of thing. So
Yeah, this is a question I guess you can answer too, but I think, one thing that was a challenge for me coming right out of school was like the acceptance, the realization, but then the acceptance that like when patients come to see me, I'm the expert in the room. And so they'll be
Mhm.
like, when I first got out of school, it was like, well, what do you think I should do? And I'm like, oof, that's a lot of power you're handing.
Yeah.
So yeah, that's a little intimidating coming
Yeah.
right out of school. But like you said, like it's been fun getting to feel out like, well, what kind of clinician do I want to be?
Mhm.
Um, and I'm in my fourth year, so I've gotten much more comfortable responding to those kinds of questions. But at
Mhm.
first, it's just like, dang, that is an intimidating question because you're going to make life decisions based on what I
I
tell
know.
you.
Yeah. Yeah. But I think the good thing is you can always be resourceful and figure it out. The people around you, the research, there's so much
Yeah,
at your disposal. So,
100%. Yeah, I mean, I would say that I had benefited from. There was only one other neurotherapist at the first job that I took.
mhm.
He's actually he and I are the same age, but he had been a PT like 3 years already when I started. And so
Mhm.
thankfully I had someone to like, you know, take me under their wing and like, bounce ideas off of. And so I was really fortunate that I did have, it was an unofficial mentorship, but he was just kind enough to be willing to take me under his wing like that. So I
Awesome.
benefited from that. I know that's not always the case. We had a
Yeah.
student at our clinic that went back to a much more rural facility in Oklahoma where I don't think
Mhm.
that was, the same expectation that she would step in and there
Yeah.
would be sort of mentor her through that stuff. So
Yeah. Yeah. Do you have any advice for students on going into their inpatient clinical rotations in terms of preparation, things to brush up on, skills?
yeah, I would say if you are really wanting to like hone in your neuro treatment skills, like practice gait training with mod to max assist patients.
Hmm.
And I know a lot of times you may get to go to a facility that has these like zero G or vector harness support systems, but depending on where you go, there's not a ton of facilities that just have that stuff. You may just have a stool and a handrail, and that's what you
Hmm.
get to gait
Yeah.
train. So practice,
Mhm.
practice, practice with that, and then be willing to take feedback. That's one of the biggest things I would say as a student is like you're
Yeah.
there to learn, and
Yeah.
so like be ready to take the constructive criticism from your CIs in terms of like, well, what could I have done better, or what like little tricks or things can you tell me, or can you show me what it's supposed to feel like whenever I have the right support at the posterior hip and the knee, and then what do I do with my hands or my legs when I'm helping advance the limb.
Hmm.
But if you can clean that stuff up as much as possible before your clinicals, I think it's going to just make it easier or more digestible for a CI to be able to like just help you shape your skills instead of like having to totally teach you how to do the hardest thing about neuro rehab, which is,
Hmm.
training a mod to max assist patient.
Yeah.
The other thing I would say is just like in terms of examination skills, one thing that I've found is tricky, but just practicing isolating, like if you're doing like a modified Ashworth,
Hmm.
practicing isolating movements at each joint. So one thing I
Hmm.
see a lot of is like you're trying to test spasticity of the hip, but you're getting a lot of knee movement too when you're like trying to do the MAS. And so,
Yeah.
all you may be picking up like mostly like quad uh, tone instead of hip flexor tone, or the opposite. You're getting,
Yeah.
maybe it's more hamstring tone that's limiting that hip extension because you're also getting the knee movement involved instead of glute tone. And so,
Yeah.
um, so I would just fine tune those more like those larger aspects of the examination as well.
Yeah.
Uh, I don't necessarily feel like you have to go into a neuro clinical like knowing exactly how you're going to run through your
Hmm.
your whole evaluation, because I think your CIs are prepared to give you tips on like ways to speed those things up. But
Yeah.
knowing from like a 10,000 foot view, like we need to screen their gross range of motion so I can get an idea of like what does it look like, and then
Hmm.
and then basic coordination tests, basic sensation tests. I don't expect many people, unless you're in like a spinal cord specialty facility, that you're going to have to know how to go through the full Asia exam or anything like that.
Yeah. Yeah, that's great advice. And I love that you had mentioned kind of practicing with the basics because you might not go to like a fancy clinic that has
Mhm.
everything. So it's better just to be prepared, at least have a mental idea of how you would go about it. And then your CI will show you when you get there.
Yeah, 100%. Sorry, you can probably hear my dogs
Oh, it's
toning.
okay.
I had a conversation with a teacher of mine who was just affirming things in me that they had seen from a leadership perspective. And one thing that is definitely true about me is that if I am not pushing for progress or change, then
Hmm.
I get bored. And so I think it's certainly true that you don't want to stagnate in the profession. And so
Hmm.
um, I have learned how to be an effective squeaky wheel. I'm a huge advocate for like promoting growth within the clinic, but the ways in which I've been able to sustain that is finding a good community. And so what I mean by that is like I've been really fortunate that The mentor that I had at my first job
Mhm.
actually took a job before me at the clinic I work at now, and
Oh,
so he
okay.
and I continue to work together at
Yeah.
this other facility. So I have found good, really supportive coworkers that
Hmm.
um, also are ambitious and like aren't just fine with status quo.
Hmm.
Um, but I also think that like continually seeking out how you can be better as a clinician. And so when
Hmm.
you look for CEUs, like don't just treat CEUs as like, well, I'll just watch this online webinar to get my hours in, but like
Hmm.
find something that's interesting to you that you will actually put into practice in your clinic, right? And so, I did that in my first year with my CSRS because I was seeing a large population of patients who had strokes.
Hmm.
Uh, and so I was able to implement that regularly. And, the same thing with my power certification. Um, and I would argue the same thing with my NCS. Like
Hmm.
after I got my NCS, like I was really, really refueled. And so I think those big CEU opportunities, whether that be BFR, whether that be CSRS, whether that be vestibular, um, I think that sort of stuff gets people excited again.
Hmm.
This is something new that I didn't know before, and I'm
Yeah.
going to take this with me to practice. And so
Yeah.
I think like really investing in high quality CEUs that maybe you'll have to travel to
Hmm.
helps ignite that spark. But trying to find a facility that has the kind of coworkers that push you to be
Hmm.
your best self
Yeah.
from a clinical standpoint. And again, I'm not sure that that exists out there for everybody in every part of the country, but
Yeah.
I, I can see why PTs burn out so quickly when they don't have the level of support that I have had.
Yeah.
Uh, I also think it's important to note that like you don't have to stay in the same setting. Like if
Hmm.
you're working in outpatient neuro or you're working in outpatient ortho or you're working in peds, like
Hmm.
you get bored, go do something else. I've had classmates who are on their like second or third job already. I had two buddies that went and worked in outpatient ortho, got super burned out with what they were doing, and now they're both working in home health. I
Yeah.
had another classmate that started off working in acute care over in Tulsa, and now
Hmm.
she's like working peds. And so, like,
Yeah.
there's mobility around the profession. If you start off as an outpatient therapist, like, you're not limited to, like, well, I guess the next job it has to be an upward movement to clinic manager, right? Like,
Right.
especially if that's in the
I
same
know.
setting, I kind of hate this setting.
Yeah.
I'm
Just
like,
add more work to that.
try something else and try travel, right? Because then that's going to give you an opportunity to do like a like multiple settings in the course of perhaps just a year, and so
Mhm.
you can get a lot of exposure. But I would say before you decide to just totally get out of the profession, like if you're not fulfilled by it, try something else, right? Because I think it's a disservice to you as an individual with the time and effort and most likely the financial investment that you had to put in to get your doctorate to not
Mhm.
see if there's something else the profession offers that
Right.
you can really find joy in and like find your niche and see if that's where you can leave your stamp.
Yeah.
I know too many people who, just a few years out of school have already left because they got
Mhm.
burned out and they just chose to do something like medical sales or realty because they were going to make more money. And there's
Mhm.
nothing wrong with making more money, but I think that's like you got into healthcare for a reason. And
Mhm.
um, if I can be a little bit of like a dad when I say this, like it's not on your employer to bring you joy in your job. It's on you, right? And so, like, if you're not working for an employer that's going to help support what you're looking for to do the kind of work that's going to bring you joy, then like go see if you can manifest that somewhere else. That may be, I'm not a boomer, but that may be like a super boomer thing to say.
I mean, it's your perspective, and I love that you had mentioned that you can always change your mind on things. I think that a lot of, at least when I did travel, I was kind of scared. I was like, should I start permanent? But then I was scared if I would get stuck, like if I would do like years and years and get burned out. So
Yeah,
I think your goals will change too as you go through the field, and there's nothing wrong with changing your mind and doing something else.
yeah, 100%, 100%. I have a question for you. Um, do you think that you've found a lot of joy and like the flexibility of like being able to take contracts with different like in totally different settings. Because
Mhm.
I was married, and I'm 32. I graduated when I was 29, and so my
Mhm.
wife and I had set some family goals, and so
Yeah.
in my mind, travel had never been an option for me. But
Yeah.
I do think travel is a good option, especially if you are really um, like motivated by variety. And so I guess I'm
Mhm.
just curious about what your experience has been in terms of, it doesn't sound like you have felt like travel has been super daunting. It sounds like from just the brief conversation I've had with you that it's actually
Mhm.
been really enjoyable.
Yeah, it's been incredibly fulfilling. I think just also the cultural like differences too. I've worked in like big cities, rural towns of like a town the size of a high school. So I've kind of seen all these different walks of life. And in addition to like the different settings, I've worked in hospital outpatient, corporate, private outpatient, and then also in acute care. So getting that variety and different perspectives, I think I've learned more in 1 year than I would have maybe like doing a couple of years in the same setting. And I'm
Mm,
okay with being a generalist right now and then eventually specializing in neuro in the future. So that's just what works for me.
yeah, for sure.
I don't know if that answers your question. I forgot the
No,
question.
no, no. I think it does. It does because I think that you have a really unique perspective as someone whose first job was going into travel contracts. And I think that you're a testament to exactly what I said, where it's like you don't have to do the same thing and you can like try on different
Mhm.
roles, see what you like the most. And
Yeah.
again, like maybe you'll get a couple of, maybe you'll end up taking a full-time position at somewhere you travel and you'll
Yeah.
decide like, I want to take on a totally different challenge and
Yeah.
shift to different gears. But I
Yeah.
have to admit, I'm like, just want to high five you because you're super into neuro, and I make fun of my ortho colleagues in our
Oh,
clinic all the time, and students that come up from the
yeah.
school
Yeah.
that are like, "Yeah, I'm pretty sure I want to do neuro," and I'll just be like, "Boo,"
Boo. Yeah.
or ortho. Sorry, they say I want to do
Yeah.
ortho, and I'm like,
Ortho,
"Boo."
yeah. Yeah. But we definitely need more neuro clinicians, I think, too, in like especially rural areas. So it's definitely an
Yeah,
underserved community.
100%.
And Austin, do you have any contact information if students want to follow you on social media or send you an
Yeah,
email if you're okay with that?
100%. So, let me look up because I'll have to check and see my YouTube, but my TikTok that I use, I have slacked a lot recently in terms of like producing normal, like regular content for videos, but I have been doing what I call NPTE night school, which is
Mhm.
just my attempt at doing some NPTE prep for
Mhm.
PTs and PTAs. I didn't initially intend that it would be something that like motivated PTAs, but
Yeah.
I had a bunch that just like joined, and I was like, sick.
Nice. Yeah.
So yeah, so I do that Sundays at 8 p.m. Central Standard Time. My handle on TikTok is at austiebaustie, exactly how you think that would be spelled.
Okay.
And then my page on YouTube is the Neuro Nerd. Mostly on there, I'm posting my NPTE Night School lives, just so
Nice.
people can like use those as a resource in the future. I'm not big on compiling my Google Docs to just like distribute to people because
Yeah.
the part of me that worked really hard to get my degree feels like
Yeah.
that's worth something. That's worth in my mind, like that's valuable. But at the same
Yeah.
time, I can't feel good about charging students to like
Yeah.
to get access to that. So I just don't publish that. But
Yeah.
I do
Yeah.
publish all of those videos. But yeah, I mean, feel free to like DM me on TikTok if you have questions about NPTE prep or just physical therapy in general. Um, I just love I love talking PT and I geek out on all that stuff. So
Nice. Yeah.
yeah.
And if you've enjoyed this video, subscribe and maybe I'll cut that part out. Thanks for watching, everyone.